Derajat, Dr. Febrianto, speaker, and all participants, and special good morning for Professor Patrick Niven from Belgium. Okay. Welcome to the Oncology Expert Sharing Forum held by Peraboy, or we call it Indonesian Society of Surgical Oncologists, ISSO, working together with Indonesian Doctor Association and supported by Pfizer. Today's topic is very interesting, raising standard in hormone receptor positive, HER2 negative, metastatic breast cancer with CDK4/6 inhibitor. Why do I say interesting? Because in Indonesia, we have so many patients coming with metastatic breast cancers, almost 30 to 40 of the breast cancer incidents. When patients come with the metastatic breast cancers, our goal of therapy is to prolong patients' lives, to delay and disease progression, and to minimize cancer-related symptoms. And those with hormone receptor positive HER2 negative metastatic breast cancer, what we can do is doing some sequencing hormonal therapy, chemotherapy, and other available targeted therapy. Yet for the past few years, there is a silver lining on the horizon with the promising result of the role of CDK4/6 inhibitor in the treatment of hormone receptor positive HER2 negative metastatic breast cancer. We have heard of the promising result even before the drug itself reached in Indonesia. Now that the drug is actually available in Indonesia, I believe Dr. Febrianto would share with us where we are now in Indonesia in terms of hormone receptor positive HER2 negative metastatic breast cancer treatment. And we are lucky, and we are very lucky today to have Professor Patrick Niven, who is going to share with us his knowledge and experience using CDK4/6 inhibitor in the treatment of hormone receptor positive HER2 negative metastatic breast cancer. As we all know, Prof. Niven work is very well recognized in the scientific community of breast cancer, shown by abundant papers published in international journals and presented in various breast cancer reference. I do hope that we all can gain more insight and knowledge about this novel treatment, and as a result, in line with the theme of today's forum, we all can rise our standard in treating hormone receptor positive breast cancer and HER2 negative breast cancer by using CDK4/6 inhibitors. Thank you very much.
Thank you for these nice words, and I'm also looking forward to hear your talk, and we can discuss after my presentation. Thank you.
Okay. Thank you very much for the opening speech of our president, Dr. Walter Gautama. So I think we could proceed with our webinar. But before of that, I want to quote the quote of the day. I quote what Blake Cady says. It was quoted in Archive of Surgery in 1997. He says, in the field of surgical oncology, tumor biology is king, and the patient selection is queen, and the technical, to add the technical surgical technique, is the prince and princesses. Usually, we try to usurp the throne, but usually it fails. So now we can realize since decades ago that how important the biological behavior of the tumor is. So we have to really pay good attention to the biology of the tumor. So this morning webinar is very good and beneficial for us, because if we follow what Dr. Febrianto and Professor Nathan said, we can give the best practice to our patients, and they will be in a good hands. So that is my opening for this webinar. And let's proceed to the first speaker. The first speaker will be Dr. Febrianto Kurniawan, or Dr. Anton. He is an experienced surgical oncologist and is currently practicing in Darmais National Cancer Center, Jakarta. It's already on the screen. So Darmais National is the Indonesian National Cancer Center. And she is also the treasurer of our Indonesian Society of Surgical Oncology. Dr. Kurniawan will be presenting the topic where we are now in hormone receptor positive, HER2 negative metastatic breast cancer treatment. So Dr. Kurniawan, you have 20 minutes and the time is yours.
Okay, thank you Dr. Derajat for this opportunity. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi.
Good afternoon, ladies and gentlemen, Dr. Walter, my beloved teachers, senior and friends, and good afternoon, Prof. Patrick Niven. It's really nice to see you here and can join us in this discussion. Okay, this time I have a job to bring some material about breast cancer, especially in hormonal receptor positive, HER2 negative metastatic breast cancer. Where are we now? What do we have in this kind of situation? And most important is, what do the patients have in the world and especially in Indonesia? Do they have a chance to get what it should? Global data show us that breast cancer is still #1 in providing cancer in new cases in 2020. It's in both sexes, if you notice. And of course, moreover in female patients, but thank God it's only #5 in number of deaths in 2020. So it seems like we are in the right track in treating breast cancer, I guess. So what's about in Indonesia? In Indonesia, breast cancer is also #1 in new cases in 2020. But we are also unfortunately achieved #2 in number of deaths in 2020. So what is going wrong in Indonesia? What have we done? I hope we will see part of the answer after this presentation. And in recent years, breast cancer has increasingly been recognized as a biologically heterogeneous disease. And thanks to advances gene expression profiling and massively parallel sequencing. And as we can see, based only on standard immunohistochemistry, breast cancer can be classified into 3 main groups: hormonal sensitive, HER2 positive, and triple negative breast cancer. And according to data sales, among breast cancer patients with known hormonal receptor positive, HER2 negative, hormonal receptor and HER2 status, as we can see that hormonal receptor positive and HER2 negative is the most common case. It's about 72.2.7%. So the majority of patients in breast cancer is the patients what we are going to talk about. So what should we have done in treated patient with advanced metastatic hormonal receptor positive HER2 negative breast cancer? And I will show you 2 guidelines international recommendation from NCCN and ESMO ABC 2020. As we can see here in NCCN, give systemic therapy or chemotherapy here a little more much space, even if there is no visceral crisis, especially in postmenopausal women. They come straight to chemotherapy. And in other chart, they give endocrine therapy a little space in condition no refractory in endocrine therapy for patient with progression or unacceptable toxicity on first-line endocrine therapy. Me, myself, is more suitable with ABC ESMO recommendation here. As we can see, they only recommendation chemotherapy to patient with visceral crisis or if there is no further endocrine therapy option. So in ABC ESMO 5 recommendation, as we can see, endocrine therapy is still preferred treatment option. And now I try to differentiate the therapy to hormonal receptor. So I try to differentiate therapy, hormonal receptor positive, HER2 negative, MBC to 3 classification: endocrine therapy and targeting therapy, chemotherapy, and combine of endocrine therapy targeting and chemotherapy. We know that patients with estrogen receptor agent positive metastatic breast cancer often respond to ET alone or in combination with targeted agent, which can reduce tumor burden and symptoms with generally fewer side effects and toxicities than chemo. Like I said before, I just use chemotherapy only for visceral crisis of if there's no further ET option. And what about combined ET and CT? A common concern is whether patient with hormonal receptor positive tumor and symptomatic rapidly progressing metastatic disease should be considered for a combined modality treatment with chemo. A systematic review of RCT by Fossati, if I can remember, comparing CT alone and CT plus endocrine therapy, have shown a higher response rate, but no survival advantage for combined treatment. So hormonal and targeting is still the main modality we have now. And the choice of therapy depends on the disease-free interval from the end of the adjuvant therapy, whether or not the patient is asymptomatic, and if so, the severity of this symptom, and whether the tumor is hormonal, receptor positive or negative. Then there are several types of endocrine therapy, as we can see. This can be characterized as a strategy to deplete the estrogen or to directly targeting the estrogen receptor. To deplete the estrogen, we can use ovarian ablation or ovarian suppression with GnRH agonist to make the patient in postmenopausal state. But even ovarian estrogen production disappear with menopause, postmenopausal women, as we know that still continue to produce low level of estrogen by aromatase activity in peripheral cell. So for this kind of situation, we have anastrozole, letrozole, azole compound, and the third is we have exemestane, is a steroid. And prospective RCT in both the adjuvant or metastatic setting have demonstrated that the clinical activity, side effect, and toxicity of these three AI are almost identical. And the choice of any of them, I think, is appropriate. And for the targeting estrogen receptor, there are two strategies. We can use selective estrogen receptor modulator, tamoxifen, aloxifen, or lasofoxifen, or we can use selective estrogen receptor downregulator for fulvestrant. Tamoxifen is a SERM, we know. Aloxifen is a second generation SERM, appears to be a weaker SERM, and it's not indicated to the metastatic treatment of breast cancer, and it's only indicated for the prevention setting, I think. And lasofoxifen is a third generation selective estrogen receptor modulator, which is now under investigation versus fulvestrant in hormonal receptor positive HER2 negative MBC with ESR1 mutation. And fulvestrant is the only we have in the world available agent that down-regulated ER. And this is our right now the beta style for hormone receptor positive HER2 negative MBC. Over the last decade, several prospective randomized clinical trials have demonstrated that addition of some targeted agent that mechanistically work in different ways that through ER interference can give the benefit than with endocrine therapy alone. In particular, CDK4/6 inhibitor in combination with ET that I will discuss below are often used as a first-line therapy. Three separate agents, palbociclib, ribociclib, and abemaciclib, which inhibit CDK4/6, substantially improve PFS, progression-free survival, when added to endocrine therapy as a first-line or second-line therapies. And we have two everolimus, an inhibitor of the mechanistic targeting of rapamycin or mTOR inhibitor, has also demonstrated improve in PFS when added to endocrine therapy in the endocrine resistant setting. And for the tumor with PIK3CA mutation whose cancer have progressed after treatment with an EA, the addition of PI3K inhibitor alpelisib to fulvestrant also improve PFS. And for we all know, PIK3CA mutation occur in approximately 40% of patients with hormonal receptor positive, HER2 negative breast cancer. And for BRCA1/2 mutation, we have PARP inhibitor olaparib for HER2 negative metastatic breast cancer. So, and at this time, there are no RCT addressing the optimal sequencing of these various targeted agents on their combination in patients receiving ET. But because of the side effect profile of the CDK4/6 inhibitor appear more tolerable than everolimus or alpelisib, I prefer using CDK4/6 inhibitor rather than everolimus or alpelisib as the initial targeting therapy to partner with endocrine therapy. As we can see in Paloma 2, Mona Lisa 2, and Monarch 3 have shown us that among postmenopausal women with hormone receptor positive breast cancer, combination of the EI letrozole with CDK4/6, palbociclib, ribo, or abemaciclib have demonstrated improved PFS relative to an AI alone and have been approved by the US Food and Drug Administration FDA in this setting. And in cross trial comparison, no statistically significant differences in PFS were found among the three CDK4/6 inhibitor in combination with AI. Palbo plus letrozole versus ribo plus letrozole, or palbo plus letrozole versus abemaciclib plus letrozole, and abemaciclib plus letrozole, anastrozole or letrozole versus ribociclib plus letrozole is just the same. And for second-line therapy, actually there is no optimal sequence for ET upon progression. An option available in second-line setting include fulvestrant, monotherapy, or in combination with CDK4/6 inhibitor. As we can see, Paloma 3, Monarch 2, Mona Lisa 3 have shown a benefit improving progression-free survival in all CDK4/6 inhibitor. For those with PIK3CA mutation, fulvestrant with the alpha isoform specific phosphoinositide PI3K inhibitor alpelisib show an improved PFS in SOLA-1 trial. And everolimus with exemestane give a good result too in Bolero 2 trial in improving PFS. So a choice between treatment depends on the patient's previous treatment history and tolerance of treatment. And studies too show that the mTOR inhibitor everolimus in combination with either an AI or exemestane is an option for postmenopausal women for the treatment of AI-resistant advanced ER-positive breast cancer. And for the third-line therapy, the treatment is individualized based on their prior treatment response, tumor burden, and preferences to treatment. And for premenopausal women, the therapy basically not different with postmenopausal. We just make the patient in postmenopausal state and then treatment just like postmenopausal women. So these are drugs and regimen that's available in the world. From the very beginning, tamoxifen was approved until alpelisib into 2019. What about in Indonesia? In Indonesia, we have almost all kind of these drugs, but of course for a very selected people. But most of patients cannot reach this drug because of the Indonesian National Health Insurance only covers small amount of those drugs. So this drug only offering suppression, aromatase inhibitor, anastrozole, letrozole, exemestane, and tamoxifen. This drug is all we have in our hand in Indonesia in treating this kind of patient for almost most of patient. So we don't have much. We don't even have fulvestrant here. That was approved nearly 20 years ago. Even less CDK4/6. Of course, in this kind of situation, the choice of chemotherapy, what we have done, become relevant. And different from my statement in the beginning of this presentation, I admitted that in our country, guideline from NCCN seems like more appropriate with our condition. And we have to get used to it. And for the last one, these are some latest study. There is some of them still going on in the world. We have responder study, the 5 years disease-free survival as well OS were improved with the additional of chemo to endocrine therapy in premenopausal, but not in postmenopausal women. In hormonal positive, HER2 negative, lymph node positive breast cancer. And so we have two phase 3 CONTESA study. Treatment with the novel oral taxane, testotaxel in combination with the capecitabine seloda in patient with HER2 negative hormonal receptor positive metastatic breast cancer. It's also result in an improvement compared to capecitabine alone. And we have phase 2 trial ELAINE-1 for estrogen receptor 1 mutation, ESR1 mutation. We know that ESR1 mutation lead to endocrine therapy resistance and poor prognosis, and monotherapy with lasofoxifene, a third generation SERD, selected estrogen receptor modulator, is being compared against fulvestrant in pre and postmenopausal women in metastatic breast cancer. And we have ELAINE-2 trial that assessing the safety of lasofoxifene in combination with abemaciclib. And we have clinical trial to evaluate OP-1250. OP-1250 is an early available small molecule complete estrogen receptor antagonist or SERAN and a selective estrogen receptor degrader SERD. And it's currently being evaluated plus palbociclib Ibrance. We don't already have the result yet. So this slide will be final of my presentation, and I will give back my screen to Dr. Derajat, Mr. Moderator. Thank you for your attention.
Thank you, Dr. Anton, for your comprehensive presentation about how is the present in our country. If there is any question, please, but it will be discussed in a special session, the Q&A, after all the presentation of the speaker. So now we come to our distinguished guest from Belgium, Professor Patrick Nathan. He is a practicing oncologist, gynecological oncology, at the Katholieke Universiteit Leuven, Belgium. Breast cancer multidisciplinary team at the Katholieke University Belgium. And also he's already started his professional career since 1986 and has been working in Belgium and in UK. And he is specialized in breast cancer. And he is a very productive writer. He also published more than 500 published in national and international journals. So he is also a part of the research team in the clinical group of palbociclib and Paloma-2. And with all experience and comprehensive background, we believe Professor Nathan is going to address this presentation very well. And please hear what he says. And the time is yours, Professor Nathan. I hope I pronounce your name correctly, Professor Patrick Nathan. The time is yours.
You did pronounce my name well, Professor Suardi. Thank you so much for having me. Can you see my screen?
Yes.
Okay. So this is my hospital in Leuven. You're all welcome. If you are in Belgium, I can pick you up from the airport if COVID allows, and it's about 20 minutes from Brussels airport. So you're all welcome.
Thank you.
Here you can see my disclosures. So I'm a full-time academic employed by university hospitals and University of Leuven. I am a member of Oncology Drugs Working Group for Reimbursement, and I try to help my patients with the best available treatment. And you can see that the honorarium for this lecture was paid to UZ Leuven. So raising standards in hormone receptor positive, HER2 negative metastatic breast cancer from clinical trial to clinical reality. And Dr. Febrianto has given us a very nice overview. So I can now focus on some of the details. So the situation in Belgium, I will show you one slide, the purpose and modalities of treating this type of metastatic breast cancer. What we have improved prior to CDK4/6 and still today remains a good treatment option. And then I will focus on the endocrine sensitive population, mainly focusing on Paloma-2 data, because I guess this is the reason why you have this meeting, because you're going to have the introduction of palbociclib in the very near future. And I'll also show you, apart from Paloma-2, some real-world data. So here you can see the situation in Belgium as presented for my hospital. In 2012, we published our data on 4,000 consecutively treated patients. In my center, we have about 600 new cases a year. This might only be a fraction of what some of you are treating in your huge hospitals. And about 10% of the patients with primary operable breast cancer have triple negative tumors, defined as an ER EHC status of 1% or more to be positive. So 8% is ER positive, HER2 positive, 4% is ER negative, HER2 positive, and then we have 78% of being ER positive, HER2 negative, and the majority of these patients is grade 1 or grade 2, because what you here see is presented as luminal A-like and luminal B-like. In the middle, you can see the ER and HER2 expression in patients who presented with primary metastatic breast cancer. In our institution, it's less than 5%. And then on the right side, you can see that the patients who have a secondary relapse, They have about similar proportions of ER and HER2 expression, a little bit more for the patients had grade 3 cancers if they are ER positive, HER2 negative, as compared to grade 1 and grade 2. So the message here is that most of the patients also in my institution are ER positive. So treating stage 4 ER positive, HER2 negative metastatic breast cancer, it's a palliative treatment, but in some cases, and I'm sure also in Indonesia, it can become a long and chronic disease. So we have to balance throughout the consecutive treatment lines, toxicity also with efficacy. So today we can prolong time to progression, we can prolong time to endocrine resistance, prolong duration to give chemotherapy, and we have been able to improve quality of life over the last 20 to 30 years in patients with metastatic breast cancer. We have single agents, we have good combination therapies. There are new molecular pathways that can be targeted, and we have many factors to treat these patients, and many of them are predictable, but not all. So which are the variables that we have to take into account, as was already presented by Dr. Febrianto? Is it primary or secondary? If it's secondary, is the patient relapsing on or after adjuvant endocrine treatment? What is the time to the treatment-free interval? Is it one organ? Is it multiple organs? The number of lesions? What is the quantitative estrogen receptor expression? Is it between 1 to 10%, or is it more than 10%? We also do quite a lot of next generation sequencing, particularly to find PIK3CA activation. Age is important, performance state. Does the patient tolerate treatment? Is the drug available? Like I just learned that you don't have fulvestrant because it's quite costly. So 2021 in my country and also in your country, we tackle the estrogen receptor pathway. As you can see, the activity on the estrogen receptor is leading to cell proliferation through the cell cycle, and estrogen receptor binding leads to activation of the cyclin D1 CDK4/6 pathway, leads to phosphorylation of RB1, and leads to proliferation through the G1S transition into the cell cycle. So estrogens can be blocked by SERMs, by aromatase inhibitors, by SERTs. We have all heard about that. Also blocking the ovarian function is also available in Indonesia. But don't forget the past. This is a patient that was relapsed with a secondary breast cancer. 7 years ago, she presented with a raised CA 15.3, and she had multiple osteoblastic bone lesions, and she was given tamoxifen, and you can see the peak of the serum CA 15.3 coming nicely down with a simple old drug, 50 years old, tamoxifen. She also was giving the bone reinforcing agent zoledronic acid. And it took quite a while to convince the clinicians that not tamoxifen was the first option, but a non-steroidal AI or a steroidal AI like anastrozole. We needed a meta-analysis to convince us that the aromatase inhibitors were giving us a better OS. So still today, tamoxifen remains also in my country an important drug, but I agree, not first or second line. Since the aromatase inhibitors, a lot of other efforts have given us a lot of opportunities like fulvestrant and everolimus, as already presented by Dr. Febrianto. Here you can see the Falcon trial on the left, showing that fulvestrant in patients with endocrine sensitive, naive, so never treated ER-positive metastatic breast cancer do better with fulvestrant than with anastrozole, with a median PFS of 2.8 months, but on the right side, you can see that this is really seen in patients with no visceral disease, where you can improve your median PFS with 9 months. Another effort is combining fulvestrant. Can you still hear me? Okay. Another effort that has shown improved PFS and also OS was not confirmed in the European study, which is called FACT, but the SWOG 0226 study published in the New England Journal of Medicine has clearly shown that if you combine fulvestrant, the SERT, with the aromatase inhibitor, you have a better PFS than if you only give anastrozole. And this is also reflected in a better OS in patients that never received tamoxifen previously. So 2 efforts in endocrine sensitive disease and 1 important effort in endocrine resistant disease, where we can add the mTOR inhibitor everolimus to actually improve the PFS with a non-significant improvement of OS. But as you all know, you have maybe this drug not available, but it does give quite a lot of toxicity. So this is not our priority in endocrine resistant disease. Still, there is an important place for this combination. But as mentioned, the last 5 years really have given us a revolution of treating this disease and improving the standard of care. So these CDK4/6 inhibitors, they do block the cyclin D1, CDK4/6, CDK4/6 activation pathway, so to block the cell cycles at the G1S phase. It's an oral treatment. It can be given cyclically, like with palbociclib and ribociclib, or continuously, like with abemaciclib. It gives quite a lot of toxicity, and commonly seen toxicity are hematologic and gastrointestinal. Rarely we see thromboembolic events and interstitial pneumonitis, and we have to be very careful when we prescribe these drugs, especially to the elderly population, because there is quite a lot of potential interaction between compounds. So to share my first experience with a CDK4/6 inhibitor, and we published other experiences in breast cancer research and treatment from UZ Leuven through a medical need program for palbociclib in patients with very advanced treated ER-positive metastatic breast cancer. You can read our experiences in these patients in this cited paper. But this unusual case is a patient who was 51 years in September 2006. She had a white excision, axillary clearance for a grade 2 ER-positive, HER2-negative tumor, and it was a PT2-1A with positive lymph nodes, and she was treated with adjuvant chemo, adjuvant radiotherapy, and she was given 5 years of a non-steroidal AI, anastrozole. 6 years later, unfortunately, she presented with bone metastatic disease, and she was consecutively given exemestane, tamoxifen. You can see by that time we did not have available these drugs. Then you can see on the graph, on the curve, the serum CA 15.3 when she was receiving a taxane, paclitaxel. You can see that the tumor marker went down and she became very quickly resistant to paclitaxel, and then she was given a CDK4/6 inhibitor. And you can here believe us that this is the CA 15.3, that she had a PFS of 33 months in 4th line. So this was for me my first experience of this group of drugs which is very impressive. And then you can see that if she relapsed, that she still had advantage of other therapies, and also that she was having a HER2 mutation, but unfortunately she could not have been given it because she died after that time. So, but this was my first experience, and you can see that this is very impressive. So what happened with the development of these CDK4/6 inhibitors in the world? You can here see a couple of pivotal trials for the 3 compounds that were being tested in first and second line mainly, against the standard of care, which was a non-steroidal AI or a SERT. And these trials were almost all very successful. So that means that our new standard paradigm in 2021, and you have seen the guidelines from ABC, from NCCN, and that in patients with endocrine naive, endocrine sensitive disease, post-adjuvant AI, and or prior tamoxifen, that this is an option that you can give the combination of treatment. And you can also, as was mentioned and also is still mentioned in the NCCN guidelines, you can still start with endocrine treatment alone and give the CDK4/6 inhibitor in second line. But of course, if you don't have fulvestrant available, you have to go for the first line treatment. Also in my institution, we do not give chemotherapy too quickly, and we reserve chemotherapy for patients with severe organ failure. So let's focus now for this oncology expert meeting to Paloma 2. It's a key study that was pivotal to get FDA approval of palbociclib, and we have it in Belgium now available since the last 3 years. So the trial is a phase 3 trial. It was multicentric, it was international, and the group of patients that were selected were patients who did not have received prior treatment in the metastatic setting. They were postmenopausal. They had ER-positive, HER2-negative metastatic breast cancer. There was a 2-to-1 randomization, 666 patients. They were randomized to the aromatase inhibitor letrozole plus or minus placebo or palbociclib given in a 125 milligram once daily, 3 weeks on 1 week of modality. In red, you can see that Paloma 2 did include a significant number of patients actually that relapsed also within 12 months of ending the adjuvant setting. This is important when you compare different studies with each other. But most of the patients were either de novo metastatic or relapsed 12 months beyond completion of adjuvant treatment. Here you can see the patient characteristics, 2-to-1 randomization to the palbociclib arm. Median age was 61, 62, so there were no differences between the group of patients. Also the patients with stage of disease at initial treatment, sometimes a long time ago. Here you can see the number of patients who actually relapsed within 12 months of ending the adjuvant treatment, which is 1 out of 5 patients were what we define today as endocrine resistant, because they relapsed within 12 months of adjuvant endocrine treatment. Half of the patients had visceral disease, and you can see the prior adjuvant treatments that the patients did have received, and they are well balanced between the groups. Here you have the main outcome. You have on the left portion of the curve the primary presentation, and on the right part of the curve you have the extended follow-up, which was published in 2019 by Professor Rigaud from the US. And you can see a clinically significant improvement in median PFS of 13 months, which is spectacular. So this improvement of PFS is more than unbelievable. And it's logical that the FDA approved this compound, and also that you will get access and hopefully reimbursement very soon. And you cannot see any group of patients who were not able to do better with the combination than with letrozole. So far, we don't have a biomarker to select patients not needing to have this combination. The only biomarker is the estrogen receptor. So people are looking into biomarkers. Also in our institution, we are helping the industry to look for biomarkers, but so far we have no biomarker that we can use in the clinic. Also, you can see here that the site of the disease, the number of the prior endocrine treatment or no prior endocrine treatment. So this is all working in the young patients, in the elder patients. So the combination is really better than single agent letrozole. Here you have some key results from secondary endpoints. Complete responses, of course, we don't expect, but they do happen, mainly partial responses. And in the patients with measurable disease, if you have an objective response in 55.3% of the patients, this is impressive. Here you can see the waterfall plot for the patients with measurable disease, that you can, when you compare the best percentage change in tumor size at any time in the patients with measurable disease, comparing both arms, that you have a clear improvement in changes from baseline according to the RECIST criteria. Here you have the exploratory analysis for the prolonged follow-up of the patients as presented by Professor Hugo. And you can see that the time from randomization to the first line of chemotherapy was also significantly improved with 11 months. And if you can delay chemotherapy, this of course is a big advantage. So the delay of giving first subsequent chemotherapy is also a quality of life important improvement. Again, the patients in both arms were able to get subsequent anti-cancer therapies when they were also in the extended follow-up publication. You can see what the patients did receive after progressing in the trial. And here you can see the continuation of the previous slide, that most of the patients were still able to get decent treatments, and I guess also available in Indonesia. So you should realize that you are not giving up on subsequent treatments if you start with this excellent combination. Here we have the all-cause adverse events as reported in the PALOMA-2 study. And we know that hematological toxicity is frequent, but you should not be put off by this, because we almost never see febrile neutropenia. It's reported in less than 2% of the patients in PALOMA-2. We have a follow-up schedule that we should respect to give this combination safely. And you can also see that other side effects were more common with the combination than with letrozole alone. So we can also focus on alopecia, which is not complete alopecia, but any grade alopecia is not unlikely. So you have to warn the patients that this might be possible. There is no more arthralgia, there is a bit more of nausea, there is more fatigue. So this drug is not without side effects, but it's the same as with the two other CDK4/6 inhibitors. But as compared to abemaciclib, we here have less diarrhea. There is a bit of more diarrhea, but this is only 7%. But with abemaciclib, 9 out of 10 patients do get diarrhea, but there is less hematological toxicity, which is a bit more seen with ribo and with palbociclib. So these compounds do have side effects, and here you see a continuation of the side effects from the previous slide. So were we able to give this compound as was expected? What you can see here is that some of the patients do need dose reductions. The majority not, but you can see that 36% had a dose reduction. But still, if you have to reduce the dose from 1 to 5 to 100 or even 75, there still is activity. So you should not be scared of, and you have to find for each individual that you give this compound the best dose. And you can trigger the best dose after 2 cycles, which means after 8 weeks, giving it 3 weeks on and 1 week off. You can titrate based on the neutrophil count, the best treatment option and drug dose for this patient. So here is a summarization of the safety. Most of the time, the side effects are low grade. We have some patients where we see induced infections, but this is very rare. You have a lot of hematological side effects. You have to adapt or trigger the dose according to the absolute neutrophil count. Pulmonary embolism has been mentioned as a potential side effect for all 3 CDK4/6 inhibitors, but this is rare. The same for interstitial lung disease, which was a little bit more seen in Asian countries than in Europe. So pneumonitis, if your patient is developing a cough, you should know that this is a potential side effect, but less common than we see with everolimus, for example. So quality of life is important, and patients in Paloma 2 were also included in quality of life studies. They were assessed by several questionnaires, and this was very extensively studied and published in this reference, published by Hari in 2018. And you can see that the combination of palbociclib and letrozole maintained health-related quality of life issues in postmenopausal patients, independent of their age. And there is no harm giving this compound. If you can double your median PFS, I think this will be, for you guys in Indonesia, a new clinical experience that you will use, and your patients will benefit a lot. So to summarize the findings of Paloma 2, not only doubling your PFS, but also a safe combination. You should be aware of neutropenia, and health-related quality of life is doable. So we don't have yet, after so many years, reached a decent overall survival benefit of this combination, but this will, I guess, be announced after a couple of months. And we all do expect this, as what has been seen with other real-world data. Putting this in perspective with other CDK4/6 inhibitor trials in endocrine-sensitive disease, we have from Dr. Febri Yanto seen that there are several trials testing this combination. And if you compare trials with each other, you can compare Paloma 2, for example, with Monarch 3, but you should realize that 22% of the patients in Paloma 2 were actually endocrine resistant. And if you have this combination, in Indonesia, please do give it in patients with a relapse. And I hope you can within the criteria of Paloma 2. So other experiences from this combination, if I can, Mr. Chairman, are data that were presented at meetings and published real world progression-free survival analysis from this Flatiron database, an electronic health-related database from the US, representing over 200 cancer centers in the US, and the experiences of these people have been presented or published. Patients treated with the combination of palbociclib and an AI in this huge database. In these patients with these characteristics, 813 patients. And you can see that independent of the age groups, that there was even an improved PFS in the elderly population. So I think this is worthwhile mentioning. These people, they did in the US from the same database, study differences of overall survival with the combination compared with a historic group of patients that they were selecting matched for the patients they were treated with the combination. So it's a retrospective analysis from the Flatiron database. You can see the included patients. They compared 1,430 individuals with letrozole and palbociclib treatment as compared to a historical group of patients with letrozole, 658. They were matched. Here you can see the details of these patients. It's a very busy slide, but I will make my slides available to your organization so you can study this more into detail. And here you can see the results that there is in this observational retrospective analysis, a clear overall survival benefit as compared to the matched letrozole alone patients of 8 months. So here you can see the OS. This is the PFS, which is on the left side unadjusted, on the right side adjusted. So PFS, you gain 8 months. And you can see that for OS, this was 38 months overall survival as a median, not reached yet in this electronic database from this group of investigators by Professor De Michele, presented at San Antonio 2019. So I got some questions from your group, and before we end this presentation, I got the question, what is the parameter to measure the success of palbociclib treatment? Do you base this on laboratory or PET-CT? We in UZ Leuven, we use quite a lot of MR, whole body, diffusion weighted MR. And this is a very cheap technique, but you need an MR machine. We do use PET-CT, of course, and we also use, if patients have elevated CA 15.3, we use this serum marker. I have a couple of slides to present you what makes the difference between the three compounds. Can you share some clinical experience for the surgeons? And how do you manage toxicity? So I will present you a case of oligometastatic breast cancer. And this is a 49 years premenopausal patient. She has 3 children. In March 2019, she presented with a CT4B. So there was skin edema. N3, M1 breast cancer, and M1 because she had lymph nodes in her neck. She had a lot of lymph nodes in her left axilla. It was a lobular breast cancer and she was inoperable. Here you can see the lymph node from the diffusion weighted whole body MR scan prior to palbociclib and letrozole. as she was premenopausal, we had to put her ovarian function on rest with an LH-RH agonist. So after 6 months of treatment, you can see that the lymph nodes disappeared from the axilla, and she had a complete metabolic response on PET-CT. The response was not complete clinically, but the metabolic response on PET-CT was impressive. I guess you will all tell it's also possible without palbociclib, but in this case, because in Belgium we can give it for locally advanced inoperable, and we call this patient oligometastatic. So this made this patient operable. And as you are surgeons, I think local control in these patients is very important. If you have local aggressive disease, well, you can make some of these patients operable, but unfortunately, and as expected, she still had a lot of remaining disease. But apart from the clearance of the axilla, she also had neck lymph nodes removed by the head and neck surgeons. And there was quite a lot of residual disease burden. And in this patient, we did give the adjuvant treatment after the combined endocrine treatment. She also was irradiated, and she now is put on letrozole single agent treatment. We could have given her the combination, but the patient decided just to stay on letrozole, and we explained her that we can always build in the palbociclib again if the disease becomes progressive. So how do we follow this patient? Because she was oligometastatic, and I hope she is now disease-free, but of course she has a very high chance of relapse. And we do monitor her with PET-CT, as we have done now already for the year 1 follow-up, and she was still fine. So I want to warn you, if you prescribe CDK4/6 inhibitors, also letrozole, that you should be careful when you combine this compound with anti-infective agents, with anticoagulants, even with cholesterol-lowering drugs, analgesics, psychotropic drugs, anticonvulsants, that you have to realize that CYP3A4 is important to metabolize palbociclib. And if you have other drugs or compounds or food supplements that might interfere with CYP3A4 being inducers or inhibitors, that you can lower or you can increase the dose of palbociclib. So you should be very careful. And the tool that we use in Leuven is called cyclibtool.org. It's very easy to handle. And if you have a patient with polypharmaca, you better give this other drug into the tool, and then you get a warning if you have to be cautious because of drug-drug interactions in combination with, for example, palbociclib is different from ribociclib and can be different from abemaciclib. Here you can see another example, and you can read this paper in this published tool. If you prescribe, for example, SSRIs for patients who might have depression or who you want to relieve their hot flushes. So coming on to an end, ECG is not a problem with palbociclib. It is with other CDK4/6 inhibitors like ribociclib. The small number of increased QTc prolongation, so the cardiac repolarization, is more a problem with ribo than with palbo. And in UZ Leuven, we don't use ECGs to monitoring these patients. However, we do on a 2-weekly base, for the first 2 cycles, we do monitor the absolute neutrophil count, and we adapt the dose accordingly. And I'm sure that Pfizer will provide you with this schedule. And you should realize that you might have to adapt the dose in a quarter of the patients. And maybe in your country, it's a little bit more than in my country. but I guess that Indonesian patients were also included in the trials, and some of you might have already a large experience of these compounds in the trials. And here you can see that a dose reduction is a stepwise process from 125 to 100 to 75 based on the neutrophil count. And sometimes you have to await another week, and you can start on the same dose and you have to test again. But if you have repetitively lower absolute neutrophil counts, grade 1, grade 2, grade 3, then you have sometimes to adapt the dose. But this is quite straightforward. And in my experiences, I have not seen patients with febrile neutropenia in the last year. So this is my concluding slide, Mr. Chairman. We never have had such good treatments in patients with ER positive, HER2 negative metastatic breast cancer, and the introduction of the CDK4/6 inhibitor palbociclib is clinically very relevant. There are a lot of other data to come in ongoing trials. And we know that we not only have other CDK4/6 inhibitors, but also newer SERDs. And I do hope that with the off-patent of fulvestrant, which was off-patent, I guess, on the 1st of April of this year, that with a cheaper price, you can obtain fulvestrant. I think the price now is 20% only of the initial price, with a lot of other companies having SERDs that you have also SERDs introduced in Indonesia. We also are better understanding resistant mechanisms. And as mentioned by Dr. Febrianto, we do have PI3 kinase inhibitors also available, but not yet reimbursed in Belgium. But we do have this compound in the patients with the mutation. But this is mainly as follow-up treatments, and also in Belgium, we mainly start with this combination in first, or in some patients, selected patients in second line. So thank you for your attention.
Thank you very much, Professor Nathan, for your wide, comprehensive, very informative presentation that I feel encouraged to start to do what you already have done, because that will be beneficial to our patients in Indonesia. Thank you very much again.
You're most welcome, Mr. Chairman.
So for the next session, it's a Q&A session. So please, if there is any question, come forward. You have two distinguished speakers here, and they can share their experience with you. So,
if I can ask a question, do you have fulvestrant in the near future in Indonesia, with it being off patent?
Sorry, Professor Nathan?
Yes, do you have in the near future fulvestrant available in Indonesia?
Yes, we have fulvestrant here, but it was not reimbursed by the government, so they have to pay out of their own pocket.
Okay. But with the drug being off patent, we have a lot of other companies than AstraZeneca to make it available to the to the clinicians, but it's much cheaper now for the health insurance reimbursement.
Thank you for the encouragement. I hope we can have those drugs in the near future. So there's one question from Dr. Rizky Rwansyah. Is there a biomarker that reliable to define patients who will or will not benefit from addition of CDK4/6 inhibitors to their endocrine therapy? I think this question is for Dr. Febrianto. Please, Dr. Febrianto.
Yes, thank you, Dr. Derajat. Can I show the question again? Okay. For the biomarker for CDK4/6 inhibitor, as long as I know, there's no specific biomarker for the CDK4/6 inhibitor to endocrine therapy. It's just enough for the receptor hormonal positive and HER2 negative, just like the Paloma 1, 2, or 3 mentioned. Maybe Prof. Niven have another opinion about that.
So I agree with your opinion, Dr. Febrianto, and I can tell you that some of my patients, some of our patients, they start with single agent treatment if they are endocrine sensitive, like we start with an AI, or we have fulvestrant single agent reimbursed in Belgium. And these patients are the ones with low volume disease, the patients with a very long treatment-free interval, the patients that also with a very long treatment interval have high ER expression in the new biopsy, because we always try to do a new biopsy of the metastatic disease. So we do have some patients where we give single agent and where we leave the CDK4/6 inhibitor till progression. And sometimes we start with single agent endocrine treatment and we add on the CDK4/6 inhibitor in these patients. And you know, if you have a patient of 75 who relapsed 10 years after treatment with a bone metastatic lesion that is asymptomatic, because I got a question through the chat box from Arga Patrianagara. Thank you so much for the question. And the question is, do you in Belgium use serum CA15.3 as a biomarker to predict metastatic breast cancer? Yes, we are one of the few countries where we do twice a year CA15.3, the first 5 years, and then we do it yearly. We know that we should not do, because this is not a guideline. It's not a guideline from NCCN, neither from ASCO, neither from ESMO, but we do it. And 1/3 of our patients, 1/3 of our patients with secondary metastatic disease are picked up by CA15.3 as asymptomatic metastatic cancers. And of course, if you have such patients, I think you can start with single agent endocrine treatment. Yes. Otherwise, we don't have any reliable biomarkers.
Thank you, Prof. Niven. So for the next question, from Dr. Rizky, is it enough for hormone receptor positive and human epidermal growth factor receptor negative to add CDK4/6 inhibitor to therapy? Please, Dr. Anton.
Yes, Dr. Derajat. I think from the trial, is it enough for hormonal receptor positive and HER2 negative patient? Just for that reason, we add the CDK4/6 inhibitor to therapy. And to adding to even for Dr. Arga Patrianagara question, for the use of CA15.3 as a biomarker, I absolutely agree for Prof. Niven, as long as I know that CA15.3 is not sensitive and is not specific for using as biomarker to predict the progression of metastatic breast cancer. Thank you, Dr. Derajat.
Thank you. And the next question from Dr. Rizky is, what is the optional sequencing for CDK4/6 inhibitors in relation to other therapies, as well as the optimal duration of therapy, please? Dr. Anton?
Yes, Dr. Derajat. I think CDK4/6 inhibitor is using almost always is in combination therapy with AI. The polymer set with letrozole. So I think the use of CDK4/6 is more preferable with combination therapy. Although Provniven said they use CDK4/6 in monotherapy setting, if I'm not mistaken, Provniven.
No, we don't use it in mono treatment. I have used it as a single agent, but this was for clinical trials. We always combine it with endocrine treatment, yes. You can use, and abemaciclib is approved by FDA, but we don't have it approved in my country or in Europe. So we always combine it. What I was mentioning, that we still use single agent endocrine treatment, and sometimes we do add on the CDK4/6 inhibitor in patients with low volume disease or with a very treatment-free interval.
Thank you for both speakers. And we come to the next question from Dr. Christina. It's especially for Professor Nathan. Besides the neutropenia, what are the other side effects of palbociclib that we can do? And then we have to do adjustment for the treatment. Please, Dr. Nathan.
That's a very good question. So if you use this compound in the clinic tomorrow, you will see that patients might, even if they have good white blood cells, that some of the patients might be very fatigued, so they might develop anemia. And this can be a reason for the patients to lower the dose. Other reasons to lower the dose are patients that develop diarrhea. It's rare, but it can happen. I have some patients who developed nausea and vomiting, so I had to lower the dose. Otherwise, I think if you explain potential, excuse me, if you explain upfront potential side effects with the patients, I think the compliance with the treatment is better, and patients can develop anemia. You can give iron. We normally don't give blood in these patients. We don't give other growth factors to these patients, also not for leukopenia. But there are quite a lot of potential symptoms that might ask us to lower the dose, to adjust the dose to 100 milligrams. And you should be aware of, I think, especially fatigue, yes.
Thank you, Professor Nathan. And now comes the question from Dr. Monica Belinda. Good afternoon. How to monitor the use of CDK4/6 in patients with cardiovascular disease? It's from Monica for both speakers. Thank you.
So in my experience, in such a patient, you should be careful with drugs that the patient is on. You should realize that there might be repolarization problems. If you have a drug with a very narrow treatment effect, that you should realize that there might be interaction, or if other drugs are added on because of cardiovascular diseases, that you should especially communicate with the cardiologist. And we are not cardiologists, so we have to decide on this together. But also these patients in my hospital, they do get palbociclib. and we monitor them with, I guess, an ECG because they have a cardiovascular problem. If they have other related problems like nephrotic problems or liver problems, there are quite a lot of comorbidities in such of these patients, and nephrotic or liver problems are not really a problem with palbociclib.
Thank you again. And the next question is also for Professor Nathan. You become quite popular here, Professor Nathan. Can current evidences conclude that CDK4/6 inhibitor be safely administered to MBC patient? It's from Dr. Ciputra.
I think that we can, in general, say, oh, sorry, excuse me, Dr. Febrianto. Please go ahead.
Yes. From Dr. Ciputra Rinaldi, I think the current evidence, the latest evidence, I conclude that CDK4/6 inhibitor is safely administered to MBC patient. All the trial show us that the only adverse event that we have to predict that we should to be careful is just neutropenic condition. So I think giving the CDK4/6 inhibitor is just reasonable for the patient with MBC patients. Thank you, Dr. Niven.
I think that we can give it safely. We should be aware of the elderly patients. We should be aware of patients with polypharmaca, and we should be careful in patients where you doubt between chemotherapy and the combination of treatment. And some of these patients, you have to monitor very closely to see whether the efficacy of the combination is good. We have patients with more than 2/3 of the liver being involved by metastatic breast cancer with abnormal liver function tests with a good response. So even if you think there is a visceral crisis or organ failure, I think most of these patients where you want very quick response, but I do have patients with bone marrow involvement and with severe liver involvement with long-lasting responses to palbociclib. So I think it's very safe to give this combination, yes.
Thank you, Professor Nathan. And now comes the question from Dr. Danny. Dr. Danny Joko asked to Professor Nathan, how about the premenopausal breast cancer patient? Could they have also a good or could be beneficial for the premenopausal?
Yes, I presented during ASCO 2019 the data for ABEMA, and Sybil Lowell, my German colleague, she presented the data for palbociclib from Paloma 3. I did so for Monarch 2. And premenopausal breast cancer patients, they do very well and at least as good as postmenopausal patients. Of course, you have to put the ovarian function at rest with LH-RH agonists. And we in Belgium, we go in patients with metastatic breast cancer quite quickly to permanent ovarian ablation. So we remove the ovaries.
Thank you. There's another question from Dr. William Stevenson. The question is, what is the preferred agent to form safety index CDK4/6 inhibitor for advanced cancer with HR positive or HER2 negative? What are the contraindications of those agents? Please, Prof. Nathan.
Question for Dr. Febrianto?
Yes.
Yes, for both of you.
Okay. Thank you, Dr. Derajat. I think it's I have a statement for Dr. Prof. Niven too. If I say that there is no chemotherapy or hormonotherapy regimen was better than palbociclib plus letrozole for PFS, progression-free survival among those CDK4/6 inhibitor, just like with Dr. William Stevenson's question. So I prefer agent if we just hold for the PFS. I think it's palbociclib is a choice among those CDK4/6 inhibitor. What do you think, Prof. Niven?
So I think that in some patients, you might prefer giving another CDK4/6 inhibitor than palbociclib. For example, if you have a patient with bone marrow involvement, you have less hematologic toxicity with, for example, abemaciclib. So bone marrow involvement is rare. I'm not speaking about bone metastatic disease. I think if you have a patient with GI toxicity from other reasons, then you might not give abemaciclib because it gives quite a lot of diarrhea, and diarrhea can be severe. So I think if your patient is less compliant with cyclical than with continuous treatment, you might have a choice between compounds. And otherwise, there is no reason why you should choose for one or the other. We don't have a biomarker. You cannot compare trials, between each other. And we know that palbociclib is the #1 in the world for CDK4 inhibition because they were the first. And I think it's an excellent drug. Also in Belgium, this is #1 as being the most prescribed CDK4/6 inhibitor.
Yes, just or maybe I can edit something that in cost trial comparisons among CDK4/6, there is no statistically significant differences in PFS, progression-free survival were found among the three CDK4/6. Thank you.
Thank you, Dr. Febrianto and Professor Niven. And here comes another question from Dr. Arga Patrianagara. He asked to Professor Niven, you present a case with MBC given the CDK inhibitor combination and it shows a very good response. Why did you and your team choose to perform surgery and not give her a second-line treatment, whether it is a chemo or other therapy? It is usually, Dr. Agra, to minimize the cancer burden, so the systemic therapy will be more effective. Professor Niven, the question is to you.
So this patient, she was young and she had locally advanced and metastatic disease with lymph nodes in the neck. So why did we choose to perform surgery when she became operable? This was because of giving her more chances with radiotherapy. So we tried to remove the bulk of the tumor, and this was done in the breast, in the axilla, and in the neck. So she had lymph node removed as much as possible to give radiotherapy a better chance. And then we did give her chemotherapy. So we gave her standard taxanes and anthracycline chemotherapy. And, I agree that some of these patients you should not operate. There is no survival benefit of operating breast cancer if you have stage 4 disease. But I think in some cases, you will all have seen that if you have primary metastatic breast cancer, that sometimes you can better control the metastatic side than the breast side, and that you should do some form of local treatment. So that's my explanation. Thank you. This is on a monthly basis, also if they have a CDK4/6 inhibitor. And after 1 year, we give it every 3 months. And there is no interaction, and we can give bone reinforcing agents in a very safe way. So yes, you should combine. I think you agree, Dr. Febrianto?
Yes, Prof. Nivan, absolutely, I agree. There is no trial that we cannot give combined bisphosphonates and CDK4/6 inhibitor. So with Prof. Nivan experience that there is no interaction, I agree that the combined is we can give to the patient with the bone metastasis. Thank you.
Thank you, Dr. Febrianto and Professor Nathan. Since there are no questions left, so I propose to the sponsor, could we end this webinar? So we come to the end of this webinar. I will read you some summary I can make. So the international guidelines recommend the combination of CDK4/6 inhibitor and aromatase inhibitor as first-line therapy in hormonal receptor positive HER2 negative metastatic breast cancer. And from the two speakers, we can resume the palbociclib is a targeted CDK4/6 inhibitor and acts good to control cell growth by inducing G1 arrest and reducing cell cycle proliferation. The combination of palbociclib and letrozole deliver PFS of 24.8 months than letrozole alone. So it will be beneficial to patients who can get palbociclib in combination with letrozole. And it has a consistent safety profile, including in the elderly, GI and toxicities and cardiac safety. But we have to be very careful, Professor Nathan said. The most common adverse effects of this neutropenia with a low rate of febrile neutropenia, like the presentation of Professor Nathan, and it can be managed by dose modification without an apparent effect of efficacy. The palbociclib is the only CDK4/6 inhibitor with a one scheduled monitoring. So those evidence supports the use of palbociclib in combination with an aromatase inhibitor as a standard of care for first-line treatment in HR positive HER2 negative metastatic breast cancer. So if the speakers know adding something, I will close this session with please give a very big applause for the two speakers. Thank you very much for your precious thoughts, precious advice, and that will be beneficial to us, the clinicians, to treat our patients better. Thank you very much, Professor Nathan. Thank you very much, Dr. Febrianto. And thank you very much for Pfizer that support us. Thank you.
Thank you, Dr. Derajat. Thank you, Prof. Nivan.
It's my pleasure. Thank you for having me, and enjoy your day and keep safe.
Bye.
Bye-bye. Thank you all, also Ruth, to get this organized. Have a nice day. Bye-bye.
Thank you, Professor Leven. Thank you, Dr. Derajat, Dr. Anton, and Dr. Walta. Thank you, participants.